You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Hey everyone, I'm Sohum Patel. I'm a second-year orthopedic surgery resident at the Indiana University School of Medicine. What we're trying to get together for you today here is a presentation on some of the most popular papers on cervical myelopathy. And we have Jose with us. I'll let Jose introduce himself.
Good day there, everyone. My name is Jose Chacon. I'm currently a medical student at the American University of Integrative Sciences in Barbados.
Awesome. So we'll go ahead and get things started here. We'll start with kind of a brief definition. Cervical myelopathy is a term that we use to refer to neurologic impairment caused by compression of the spinal cord at the level of the cervical spine. And this can most commonly be attributed to degenerative cervical disease. And we see it in older patients, and they can present pretty variably, but often we see things, in the history that are pretty telltale. We'll hear patients say they're complaining of radicular symptoms in their upper extremities. Oftentimes they can have headaches and neck pain. We can call them occipital neuralgia or occipital headaches from the muscle tightness and spasm that's associated with facet degenerative disease. And then patients will also sometimes complain of clumsiness with their hands, as well as issues with gait that may or may not be noticed by the patient, but often would be noticed by loved ones, and things of that nature. And so we can go ahead and kind of talk about some of the things we see on physical exam that are pretty high yield. So because of compression of the spinal cord and the cervical spine, we see upper motor neuron signs, and these are things that result from compression of the corticospinal tracts and the level of the cervical spine, and see things like hyperreflexia, Hoffman sign, which is when you snap the distal phalanx of the middle finger and you see a spontaneous flexion in the other fingers. You can see sustained clonus, a positive Babinski test. All these things you probably remember from medical school as being related to upper motor neuron pathology. One of the other high yield things we can see is a positive Romberg sign, which is when you have the patients close their eyes and they have problems with balance. And this can result from compression of the dorsal column, medial lemniscus tract, kind of in the posterior aspect of the spinal cord. So just to summarize, cervical myelopathy is compression of the spinal cord at the level of the cervical spine, most often caused by degenerative disease, in elderly patients. So we'll go ahead and get into it. What we did was we used an online search database to find the 5 most cited papers on cervical myelopathy over the last 20 years. And so we'll go ahead and kind of jump into the first paper. All right, so to get things started, the first paper, Anterior Cervical Discectomy and Fusion Associated Complications. This is a retrospective review out of Mercer University School of Medicine in Macon, Georgia, published in the Spine Journal in 2007. So what these authors looked at was a series over 3 years of 1,000 patients, 1,015 patients who underwent a first-time ACDF, 1 level, 2 level, or 3 level for cervical radiculopathy/myelopathy. They used an anterior approach, and what their goals were to report the complications that they saw in these patients. Of note, ACDFs are a relatively common performed spine procedure, and a majority of the outcomes are good and excellent. Complications are rare, but can be pretty troublesome when they do occur. So I think that was the value of this paper, was to allow surgeons to be familiar with what to look out for postoperatively to avoid any of the catastrophic outcomes that could be a potential there. So like I said, they looked at 1,015 patients over 3 years and looked at their complication rates. And what they found were that the most common complication rate in about 9% of patients was postoperative idiopathic dysphagia. So having some hoarseness, difficulty swallowing, and those things were common and actually resolved in a majority of the patients by hospital day 7. In the second most common complication that they had was a postoperative hematoma, which can happen, from not obtaining perfect hemostasis postoperatively. And of these, 5.6% of their patients had a postoperative hematoma, but only 2.4% required surgical evacuation due to airway compromise, and the rest were treated via observation. So that's definitely something to be on the lookout for. Postoperatively, we always go into the PACU with these patients and make sure we're evaluating the airway. And then One of the other complications they reported, about a 3% rate, was a recurrent laryngeal nerve palsy, and they confirmed this by indirect laryngoscopy, and a majority of these did resolve, in the long run. There was a rare complications that they reported were dural tears at about 0.5%, and worsening of pre-existing myelopathy in 0.2%, and a Horner syndrome, which is from loss of your sympathetic chain adjacent to the cervical spine, in 0.1%, as well as some instrumentation failure and superficial wound infections also in 0.1%. So these were the less common complications. One of the complications that they reported that had a catastrophic outcome was esophageal tear. So when you're doing your approach to the cervical spine anteriorly, you're obviously in between the esophagus and the carotid sheath. So it's definitely something you always have to be on the lookout for. And of their complications in their 1,000 patients, they only had 3 esophageal tears. 2 were identified intraoperatively and repaired by a cardiothoracic surgeon. However, 1 was not identified, and the patient was complaining of some dysphagia, and so they had some imaging done, and it didn't reveal much. And then on hospital day 2 in that patient, they got chest X-ray, which showed concern for mediastinitis, and they took them back emergently to the operating room, where there was found to be food debris and purulent material in the mediastinum. So and that patient ended up passing away from this complication. So definitely something to always be on the lookout for when you're operating in the anterior neck. So what are the conclusions? ACDFs are an established treatment for managing cervical radiculopathy and myelopathy. They're relatively safe and have good to excellent outcomes in most patients, but it is important to recognize what the complications could be, as it helps recognizing them early on and preventing catastrophic sequelae. All right, moving on to the next paper. So this paper is titled Degenerative Cervical Myelopathy, Epidemiology, Genetics, and Pathogenesis. This is also a review article published in the Spine Journal in 2015 out of the Division of Neurosurgery and Spine Program in the Toronto Western Hospital in Toronto, Ontario. So what is this paper about? What the authors were interested in is assessing the fact that non-traumatic degenerative forms of cervical myelopathy tend to represent the largest cause of spinal cord compression in our elderly populations. And this can result from multifactorial pathology, from spondylosis, aka arthritis, so what they title cervical spondylitic myelopathy, CSM. It can happen from ossification of the posterior longitudinal ligament, OPLL, ossification of the ligamentum flavum, OLF, or degenerative disc disease, DDD. There's no consistent ICD-10 code at the time of this paper being published to describe this entire collection of pathologies because they tend to coexist. So the authors were seeking to introduce the term degenerative cervical myelopathy as an overarching diagnosis to represent the combination of these entities and describe its pathogenesis, epidemiology, genetics, and risk factors. So one of the interesting things that they looked at were, how this chronic and progressive spinal cord compression causes myelopathy. So some of the things that they identified were interruptions in the blood flow, and then some microbiologic things, glutamate excitotoxicity, and then microglial activation and its regulators, as well as neuronal apoptosis, demyelination, and axonal degeneration. So they did find some genetic variants that are predisposing patients to more development of these conditions. And these are highlighted kind of in the second point of this slide. And some of these things include your collagen genes, your BMP2, and your vitamin D receptors, which could be linked to ossification of the posterior longitudinal ligament and ligamentum flavum. So there's been plenty of genes studied, but overall, we know this to be a degenerative disease pathology. So here's a nice graph that kind of shows you, the terms that they want to encompass under the DCM umbrella. So they have, spondylosis, which we also, refer to as arthritis, and then the facet arthropathy, degenerative disc disease, which encompasses, your facet cyst, facet hypertrophy, facet instability, disc herniation, bulging, and then spondylosis, or, arthritic encompassing of the foramen, and then the non-osteoarthritic degeneration, which could be from hypermobility disorders, as well as ligamentous degeneration, and that encompasses kind of the OPLL, OLF things. And then here's kind of a nice schematic diagram. It's just like looking at a sagittal cut the cervical spine, and you can see some of the anatomy and some of the pathologic features such as osteophytes, hypertrophy of the ligamentum flavum, as well as ossification of the posterior longitudinal ligament, ossification of the ligamentum flavum. They're all things that they're highlighting here on this diagram to show that degenerative cervical myelopathy, the term that they're wanting to introduce, often encompasses many of those sub-diagnoses. So conclusions. The overall conclusion is that degenerative cervical myelopathy can present as a separate diagnostic entity, it's highly related and frequently manifests in concomitance with degenerative disc disease, cervical spondylitic myelopathy, OPLL, and OLF. And there's also some congenital factors as well as some genetic predispositions to some of these features, and it's multifactorial overall. And DCM is a good way to encompass this broad diagnosis and keep some homogeneity between healthcare providers for the purposes of diagnoses and research and ease of communication. The term DCM should be used. All right, I'm going to take it away to Jose to present this next one.
For this next article, we'll present is titled Intermediate Follow-up After Treatment of Degenerative Disc Disease with the Bryant Cervical Disc Prosthesis at either single and bilateral. This is a perceptive multi-center clinical trial that was treatment for the patients with single level or two level degenerative disc disease of cervical spine. This was based out of University Hospital in Belgium, but the trial itself was conducted at the Bryant Cervical Disc Prosthesis located at the Medtronic so far in Memphis, Tennessee. Okay, basically, a little bit of background here. The fusion of the cervical disc can lead to degenerative disc levels adjacent to the fusion due to increased stress. Reconstruction of the failed interventricular disc with a function disc prosthesis should offer the same symptomatic benefits as decompression, compression, and fusion, as well as provide motion and protecting the adjacent level disc from the abnormal stresses. Basically, what the gap of this article was to see what would see the changes due to the fact of having a single level or a bilevel that either will cause any kind of complications or other considerations while doing it. So
yeah, I think that I agree. An important thing in the background to highlight is the standard of care, for cervical disease, as we kind of talked about in the beginning, is ACDF, or anterior cervical discectomy and fusion. And so that involves removing the disc material and fusing the two intervertebral levels, or two or three, depending on how many levels of disease there are. And what that can lead to is what you alluded to in your first point, adjacent segment disease. And that's an important concept in spinal surgery overall, either whether that be in the cervical or lumbar spine. And it's the idea is that, when you fuse a certain level or multiple levels, the joints that remain intact at the levels either above and below are subjected to higher stress. So that's kind of what the authors wanted to address by looking at this Bryant disc prosthesis was, is there a way to treat cervical pathology without causing accelerated degeneration of the adjacent segments to a fusion type construct? And I think that that's the value of the motion preserving surgery such as a disc arthroplasty. So yeah, I agree with everything you said, Jose. I'll go ahead and change it to the next slide.
Thank you there, Dr. Patel there. Basically for the methods this was the study they done it was started in January 2000, evaluating the device. Single level disease is second arm to the study was initiated in 2001, evaluating disease. And basically what they did was they determined this approach, this prosthesis, based upon two things: provide relief with neurologic symptoms and signs, as well as improve patient's ability to perform activities of daily living, decrease pain, and maintain stability and segment motion. Among some of the criteria they have listed there as part of the research, the inclusions include patient with disc herniation or spondylosis with radiopathy, myelopathy, which had not responded to conservative treatment. And what I mean by conservative treatments include rest, soft collars, physiotherapy, or pharmacological treatments during the last 6 weeks. And among those excluded from the study include those previous cervical spine surgery involving using any other devices, axial neck pain as a solitary symptom, significant cervical and anatomic deformity, and radiologic signs of instability, which is basically translation instability of more than 2 millimeters, angular motion more than 11 degrees greater than the either adjacent level, as well as active infections. Okay.
Awesome.
Okay, and basically from what they accumulate from the study here, it shows that there's, since the inclusion of prosthesis, that there's been significant improvement in symptoms compared to pre-operative symptoms and neurological signs in respectful treatment level. Thus, overall, the plant has alleviated pain and improved function based on prooperative physical examinations. And usually these are basically just standard range of motion and so forth, quality of life, pain scales, and so forth to determine it. And of course, some of the complications that was reported during the study from the single level, basically excavation of primary hematoma, posterior femorectomy without device involved to treat residual symptoms, and posterior decompression to treat residual metabolic symptoms. Basically, sometimes it either could be due to hypercoagulability, some bleed that led to hematoma, as well as also basically if the prosthesis itself had any kind of like a shift or motion change over time there that kind of causes further pains like spinal cord compression or any sort of that nature there, and it caused it. And likewise, in the bilateral level, it includes excavation of the epidural hematoma, excavation of the periverticular hematoma, and repair of the pharyngeal tear esophageal wounds inside during intubation. One case of CSF leak and anterior compression caused by ongoing nerve root compression. So basically, very similar to like the single level, except the level of the complications was much more kind of more severe because of its nature of it, and as well as also as mentioned earlier that these the more higher levels you accomplish from these, the greater increased chance you may have adjacent discs that can be interfered with, changing positioning or the angle could be making more retinopathy or smogopathy that could cause any further complications.
Yeah, I think that's well reported, Jose. I think that a couple of things to just highlight. Obviously in their results, they looked at 103 patients total in the single level and 43 in the bi-level, and so they're looking at the outcomes in these groups, but not necessarily comparing them to a control. So the results we're looking at are just their reported outcomes in this situation of the single level and of the bi-level. So not necessarily comparing it with anything, but we can see the outcomes they reported, and that includes the radiographic results, the position of the device, range of motion, and then quality of life using some questionnaires, the SF-36 health survey, and so on and so forth. So you can see these right here on my screen. Right here, you can see the outcomes that they reported for either the single and bi-level, and then they had great range of motion, excellent pain scores, and pretty low complication rates overall with this. But this was follow-up at their intermediate follow-up. So we'll go ahead and move on to the conclusions.
But basically, the conclusion is that, as mentioned earlier, that the data shows that properly placed device do not mitigate, and the device allows for segmented motion. Although it's mentioned in the article that they want to suggest, even though this was only done at a 1 year post-op, but what they recommend to do a long-term functionality. In this case, they say 5 years to see for the check to see if this prosthesis have now in addition to has any effect on the adjacent levels, but also any other further complications or any other issues with the prosthesis that could, for example, that could be infected or can go further complicating the spine itself there. So that's something they have suggested to see to further evaluate for safety and efficacy.
Right, and so that was what they suggested at the time of this paper, which was in 2003. Since that time, there's obviously been much more long-term follow-up in these cases, in the use of the cervical disc arthroplasty or the Bryant disc prosthesis has become much more widespread. This is just one of the more classic papers on this topic, and they've had good outcomes overall that kind of echo what we saw with the immediate follow-up. But one of the things that I've heard people say is as we see with joint like total joint arthroplasty, like with total hips and total knees, when you have a bone implant interface and motion, it can lead to loosening, osteolysis, and then with a polyethylene prosthesis, you can have particulate wear, and poly wear, and the debris in the neck, and possibility of complications associated with that, which we may not see for several years after these have been implanted. So I think that's something interesting that I've heard. I'm not sure how entirely relevant that is, but just something to keep in mind as we tend to advance surgical technology. So kind of keeping on the same theme here, I'm going to move along to a paper that's a prospective, multi-center, randomized controlled trial, to look at treatment of persistent radiculopathy or myelopathy with either a single level disc replacement or single level ACDF, or anterior cervical discectomy infusion. This is published in the JBJS in 2011 by Dr. Sasso out of the Indiana Spine Group here in Indianapolis, Indiana. So hometown for me. Let's go ahead and get into it. So what they wanted to look at in this paper was, obviously the standard of care at the time of this being published is in most places an ACDF for treating single level radiculopathy or compressive myelopathy. And the issue is that what we mentioned earlier, when you fuse a cervical level, is you get degeneration in the facets at the level above and below your construct in adjacent segment disease. And what comes along with that is further spondylosis and further symptomatic either radiculopathy or myelopathy. And this leads to more operations in patients and fusion of additional levels. So trying to avoid that is the goal. And the hypothesis would be that cervical arthroplasty in the right patients could be a substitute for cervical fusion, to decompress the neural elements. So what they did was they had about 430 patients that were randomly assigned to the groups, 242 in the arthroplasty and 221 in the fusion groups. And these patients underwent surgery via either, and obviously were blinded to the treatment that they were receiving. And then they were evaluated at, preoperatively at the time of surgery and discharge, and then at regular intervals, 6 weeks, 3, 6, 12 months, up to 48 months, so 4 years post-operatively. And then, they had their specific inclusion and exclusion criteria, which could be found in the paper. So, some of the things they looked at in this paper were the neck disability index, as well as, arm pain scores, as well as neck pain scores, and then the SF-36, which we mentioned earlier. So these were all, substantially statistically significant and higher in the Bryant arthroplasty group. So starting with the neck disability index of 90 versus 79%, as well as the neck pain score and the arm pain score. So this was at their 4-year follow-up, and they'd had no deterioration, of the cervical disc arthroplasty at the bone implant interface. They didn't see any end plate changes on radiographs, and they didn't have any deterioration of outcomes at that point in time. So, what their conclusion is that the clinical improvement continued to be significantly better in the arthroplasty group compared to the fusion group. One of the things that I think is important is looking at their patient selection in these groups. So moving on to the conclusions. So what the authors concluded in this paper is that, the arthroplasty has had improved outcomes reported, as well as low complication rates, including, no deterioration of end plates, and increased clinical improvement in the arthroplasty group at 4 years. So, and in addition, they preserved spine motion and avoided the possibility of any adjacent segment disease. what they comment on is something we mentioned earlier, is that longer term follow-up is needed for any issues that may be related to bearing surface wear, which is something that is probably being looked at now. Go ahead and take it to the next paper here and let Jose take over.
Thank you there. Next for this next article would be C5 palsy after decompression surgery for cervical myelopathy. It's a literature review, basically compiled on available studies on the concept of post-operative C5 palsy. This was published on the article Spine in 2003, and this was based out of Osaka University Graduate School of Medicine in Tokyo, Japan. Okay, the basis behind this study was to see that what is the pathogenesis, as well as also the treatment for C5 palsy, because there's been very little prior to it. There was very little information about, specifically on terms of what was the pathogenesis, the etiology, as well as also the treatment management aspect of it. They had a good understanding with it, but a very good detail on listing of basically what would be background information for it is not determined. So this was so having that in thought, this was the purpose of this paper, to see what can be done for establishing what could be done for those with post-op C5 palsy.
Yeah, I think that's a pretty good background. I think that it's something important to point out is that they noticed this in the 60s. I think they mentioned these authors Scoville and Stoops, who initially reported paresis of the upper extremity as a neurologic complication following cervical laminectomy. So it seems like that was the first time that this was reported in the literature. And these authors, who were based out of Japan, where laminoplasty is pretty commonly done, had noticed, as this became more widespread, laminoplasties, they started seeing more of these palsies, and they wanted to, kind of characterize, maybe who would get these, if they could find, statistically significant differences in surgical approach or surgical procedures, and or determine, a mechanical pathology as to why this happens, and whether that be the theory of float back causing tension on the C5 nerve root, or actually damage to the nerve root itself. And these are all theories that they wanted to investigate. And they also wanted to describe a rate. So I think that the number that they went with, you wrote about 5%, so 4.6% is what they describe it, is 4.6% rate of C5 palsy. It's 1 in 20. That's pretty high. So I think it's also important to define the C5 palsy too. So the way that we see it post-operatively, and I just saw this in spine clinic the other day actually, is weakness or paresis of the deltoid and biceps. Both of these muscles get contributions in their innervation from the C5 nerve root. So having weakness in the deltoid or biceps brachii after cervical decompression surgery, without any deterioration of myelopathy. So indicating that there's no like central compression or epidural hematoma. So that would be the definition there. We'll go ahead and move along.
Thank you for that there. Okay, basically from what they have compiled in this study here, it was able to collect about 24 studies that were reviewed and analyzed that was used as part of this study. It's kind of like how they did a kind of like a systematic review, meta-analysis approach, and basically how they accumulate all the prior studies and accumulate to a pretty much a comprehensive approach to get to the better understanding in this condition there. And it was basically, these publications were ranged from, that was published from 1986 up to 2002 regarding this this pulse-off complication. So what they did was that when they accumulated all the prior studies, they further divide them for basically, for example, what kind of surgical approaches they, for example, was a disc anterior ACDF, unilateral French door was also mentioned there, as well as also how many cases were reported in addition, as well as incidents for each each of the studies to indicate of occur C5's palsy occurred post-operatively. So once all that studies were analyzed and collected and analyzed, they determined from their results was, for what they accumulated, was that what they found out was that, as Dr. Patel mentioned earlier, that from their analysis, it was an average about 4.6% had that such complication. So there's a fairly a good amount of it that can occur over time there. And as mentioned, about 4.6% of patients had this complication, as was also it's generally, even despite having such a palsy this complication occurred, however, their prognosis seemed to be very good for the most part. Their particular neurological functions able to recover. The pains sometimes that will occur, but over time it will improve over time there. Although despite there's still some cases of severe cases that causes some paralytic complications that requires a longer time to recover, and that's as we can see there. From the studies they accumulated, the possible causes in terms of pathological course in terms of etiology includes the following: injury to the nerve root during surgery, nerve root traction caused by conservative shifting of the core followed by decompression surgery. And usually that's, if you recall from the previous study, we talked about how that can cause, depending on which approach was done, it can cause issues with the adjacent disc and cause some further issues there, like complication there. Others include spinal cord ischemia due to decreased blood supply from radial arteries, especially if those vessels has been compressed as a result of it there. Segmental spinal cord disorders, and also reperfusion injury of the spinal cord, especially these occur usually during after anesthesia recovery there. Oftentimes you have these reperfusion injuries that cause high amount of high oxygenation that can cause further damage of the vessel, and thus affecting the spinal cord from there.
Yeah, I think that, and these are all hypotheses, and what they highlight, in their discussion, is, the most important thing is that these are all proposed, and each of them remains hypothetical. There's no reliable or reproducible evidence for any of these theories, and nobody has done any follow-up studies. So to kind of just summarize, there's no known mechanism for this postoperative C5 palsy. All we can say is that, what they looked at least in this paper, is that there's no statistically significant difference in the anterior ACDF approach and posterior lamelloplasty approach. But I think there is some newer research out there that shows that people that get posterior laminectomies and fusions do have a little bit of a higher rate of the C5 palsy. And again, the mechanism is poorly understood. And I think it's important to also talk about the prognosis and treatment. So most of the time, they're treated conservatively with therapy, including, a cervical halo, cervical traction, muscle strengthening, and things like that to prevent contractures. And what they found was that if, the patients that had a muscle manual testing with muscle power less than 2 had a more poor recovery, whereas, people with an MMT grade of 3 or 4 generally had full recovery. So overall, pretty good prognosis, and, could manage conservatively when it does occur, but it's important to recognize and important to counsel patients on this as a risk of, cervical spine surgery.
Thank you there, Dr. Patel. So basically, overall, from what they conclude here is that even though as Dr. Patel mentioned earlier, that the list of possible pathogenesis for the C5 palsy it's all in theory, a hypothesis of it. And despite having that, there's still yet a specific treatment has been shown from these studies there. And as mentioned earlier, that some of the recommendation include physical therapy, muscle strength, conditioning, bed rest, halo vest, and shoulder range of motion to prevent contractures. But as mentioned, overall, there's still not specific treatment for it, and what they have even considered to determine is that they want a more precise, more studies that would look into their pathogenesis precisely, as well as also morphological changes by etiology. So basically this study has basically gave us a good layout, good framework for the causes and changes for C5 palsy, but more, as mentioned, more further studies is required to be more precise on further its treatment management, and as well as also any complications.
So I think that's pretty important, and you know, that covers these papers. Obviously, we've included the title of the paper in each of our slides, and that should be at least make it a little bit easier for anybody who's more interested and you know, wants to dig in a little bit deeper to these papers. Like I mentioned, you know, the way we picked these was by picking the most highly cited papers over the last 20 years, and sort of by default, the papers that have been around for a little bit longer obviously have more citations. So some of these, you know, tend to be a little bit older, from the early to mid 2000s, you know, but the impact is still very relevant. And I think it's important to understand how things have progressed and where we have built our current practices on today. So that's going to be all for now. And just wanted to thank you guys for listening, and see you next time.